Thank you. Our next presentation is a very important one. As you know, many individuals living with ECD have a lot of pain and fatigue that is difficult to manage. We have different forms of pain, different forms of fatigue, so it will be worthwhile to have an overview about this. So in order for us to discuss this topic, Dr. Montserrat Olmo Plaza, palliative care from the Catalan Institute of Oncology, will be highlighting her experience with this. Thank you and welcome.
Good afternoon, everyone. It's my pleasure to be here today, and I want to thank the Alliance and Dr. Solenik for inviting me and believing from palliative medicine we can help you to manage pain and fatigue, because that's what we do in palliative medicine. We try to palliate and alleviate symptoms in chronic diseases. It's very important what patients report about their feelings, their symptoms, because that's what helps us doctors to assess and treat your symptoms properly, especially in rare diseases. As you see here, both patients on treatment and without treatment, ECD patients report fatigue and aching bones or joints in a high rate. And some constitutional symptoms like fatigue, which sometimes is not related with radiological findings or blood test findings, can be misdiagnosed and mistreated, and that's something that we can't permit. Fatigue and pain are reported together very frequently, and we also have to know that one can worsen the other. It's very difficult to live with chronic pain, and it's described as an unpleasant sensory and emotional experience, and it's a personal subjective experience, so it's important that sometimes we can use more objective tools to assess properly the pain. And what we use the most is a numeric scale ranging from 0, meaning no pain, to 10, meaning an unbearable pain. We always have to respect and believe a patient with chronic pain and listen to his or her needs. We always think in the bone pain, of course, in ECD, but we can't forget the importance of abdominal pain and pain in some typical places where the disease can go, like the eyes and jaw. And we have several drugs and several therapies we can use to relieve pain, and I will explain you briefly all of them. First of all, of course, the ECD treatment, because it's expected that if you treat the disease, you will have less symptoms of the disease. But we can't forget what the colleagues told us this morning, that some of the treatments can also cause pain and fatigue. Regarding painkillers, we use the whole analgesic ladder, of course, starting with the basic painkillers like paracetamol or anti-inflammatory drugs. If the pain is not relieved, we step up to the second step, in which we have the weak opioids, codeine and tramadol. Sometimes we skip this step because it's been seen that even in more fragile and older patients, strong opioids can be better tolerated. I know in some settings, the use of these strong opioids, oxycodone, fentanyl, has been related with major concerns regarding addiction. But what I can tell you in our setting, in our experience, with a proper indication and a close follow-up, we consider these drugs as secure. The last one, tapentadol, is interestingly has two mechanisms of action, so it's not 100% opioid. So in doctors being a little bit reluctant to use these strong opioids, it could be a good option for a first one. And in the fourth step, we have the intervention treatment of pain, like going directly to the places where we have the pain and perform intra-articular or trigger points or cementoplasty interventions. Very importantly, in every step of the ladder, we can and we should use co-analgesics. Those are several families of drugs that can help us in different kinds of pain. For example, antidepressants and anticonvulsants are very used in neuropathic pain. like duloxetine, pregabalin, corticosteroids always help us because of the inflammation of present in this disease. Muscle relaxant, ketamine, patches of local anesthetic, bisphosphonates, and antispasmodics for the abdominal pain, for some abdominal pains. Corticosteroids are pretty used in ECD, and even 1/3 of patients before the diagnosis have been treated with high doses of steroids, and they really improve acute symptoms. The bone-modifying agents, we have these two families, the biphosphonates and the denosumab, and there are several reports with zoledronic acid and a good response even in the long term, like this case with 1 year of follow-up. And denosumab, it also inhibits bone resorption. And a colleague this morning tell us about a clinical trial with denosumab and anakinra in ECD patients. And this recent report comparing the use of these two families seems to find that denosumab has a greater efficacy and a favorable safety profile. So let's see how it works in ECD patients in the future or in the present. We cannot recommend the use of cannabinoid as analgesic in ECD patients yet. First of all, because it's not approved in a lot of countries in the world. And second, because medical evidence is not that clear yet. As you see here, it's only a little bit better result of cannabis versus placebo in this meta-analysis. And this means that the chronic, the pain associations really don't recommend them. As you see here, weak recommendation, only as a clinical trial, consider potential benefits and harms. And regarding this, we can't forget that cannabinoids can cause neurocognitive deterioration. And this is something that ECD patients can have just because of the disease. We can extrapolate that if these radioactive agents have helped relieve pain and decrease the use of opioids in patients with bone metastases, it can also be useful in patients with ECD. But I found very little evidence. This is an old article in which the use of strontium didn't improve the pain in this patient. But what did improve the pain was the use of interferon, which improved significantly the bone disease. About radiotherapy and surgery, it is supposed that ECD is not radiosensitive, and also surgery is not curative, but there are several reports indicating that at least in the short term, they can be useful tools. As you see here, short-term palliation, gradual response, but later recurrence of symptoms in most cases with radiotherapy. And this series of 9 patients that underwent surgery, they found a quick relief of pain. There can be not only large bones invasion, but also articular invasion. And in these cases, arthroplasties or replacement of the articulation can be performed by the traumatologist. So we have to individualize which each patient needs. From an integrative approach, acupuncture, reflexology, and massage have shown certain positive effects in treating cancer pain and musculoskeletal pain. Physical therapy that I think we will see just right now. And hopefully with all these treatments and tools that I have just explained to you, your doctors achieve that from this suffering Frida Kahlo's woman, you can have better control of your pain and have a more relaxed life, like the sister of Dali in this Dali's painting. Let's move to fatigue. Fatigue is a very common and frustrating and life-changing symptom. It's not just feeling tired, and patients very often doesn't know how to explain it to their families and friends. And families and friends sometimes can't understand that this is just not feeling tired. This description of this cancer network, this definition, I think it's very, very clear about what ECD patients feel when you explain that you have fatigue. It's a distressing, persistent, subjective, physical, emotional, and cognitive tiredness, not proportional to recent activity, and that interferes with usual functioning. As a subjective symptoms, it's also interesting to have a more objective approach to what you explained to us, and we have several scales, but some of them are too long, like this one with 30 items, and we have to look for these easier ones to give to our patients and to learn better about how the fatigue is impacting in their lives. The most important thing in fatigue, I believe, is to rule out the treatable, the reversible causes. And in this long list of causes of fatigue in general, you will see that I will check all the ones that a patient with ECD can have, and there are several of them. Of course, the endocrinological alterations and kidney failure, the cardiopulmonary disease, the malignancy, the second cancer, cancer treatments, the use of antidepressants, anticonvulsants, interferon, poor sleep hygiene because of pain or whatever, or other symptoms, the presence of anemia, the presence of depression and anxiety. As I told you, the endocrine dysfunction present in a lot of ECD patients, as you see here, is very often related with fatigue. And this very complete article about the clinical spectrum of Erdheim-Chester disease, as you see, 60% of patients have hypogonadism, 47% diabetes insipidus, 50% have some degree of cardiac insufficiency, and in the laboratory, 60% had anemia, and almost 50%, almost half of patients have chronic inflammation parameters, which is supposed to be the cause of fatigue, the chronic inflammation. So a proper medical history interrogating the symptoms of every organ, a good physical examination, a consultation to the specialist we consider indicated, and a complete laboratory test can rule out these treatable causes. Of course, treating the disease should be one of our goals. And as you see here, the treatment with anakinra achieves the cessation of fatigue in these patients. Anakinra is supposed to be especially effective in bone pain and constitutional symptoms. This review of the recommendation of several societies in the management of fatigue, you will see that it's 5 societies, very different, oncology, palliative care, nursing and psychosocial societies, and what they all recommend are to treat the reversible causes, as I just said, the physical activity and the energy conservation always recommended by a specialist, a psychological support, who doesn't need psychological support in life, some complementary therapies, mindfulness, yoga, massage, and ginseng, and almost all of them recommend a good assessment of the symptom and a sleep optimization. And where there are mixed results is in the psychostimulant medication with no consensus, and about corticosteroids that are in real life are very useful for fatigue. They recommended to use them in the short term. Why? Because there are mixed conclusions and there is little evidence of optimal dose and duration. This article found an important improvement of fatigue and quality of life with the use of dexamethasone because of the effects on pro-inflammatory cytokines. And why dexamethasone? Probably because of its long-acting effect, its very high anti-inflammatory potency, and very importantly, zero mineral corticoid potency, which skips some of the more typical adverse events of corticoids like hypertension or water retention. And this interesting article that reviewed more than 100 other articles in non-pharmacologic and pharmacologic interventions to treat fatigue, they found enough evidence to recommend exercise, to recommend cognitive behavioral therapy, mindfulness, and Tai Chi and yoga. There is less evidence about psychoeducation, but it can never harm anyone to know more about how to treat anxiety, anger, time management, and also ginseng use. Anxiety and depression are very frequent in patients with histiocytic neoplasms. 1 in 7 patients report them as moderate to severe, so we have to have very in consideration the mood in our patients. What they didn't find enough evidence was in recommending wakefulness agents like modafinil, or L-carnitine, or psychostimulants, as I said before. The most known of them is methylphenidate, and it has not been demonstrated that has more effect than placebo. Also, antidepressants had not enough evidence to be recommended. Other interventions like music, like Chinese medical therapy, like massage therapy, like virtual reality, don't forget we live in 2025, have shown some grade of improvement in our patients. And coping skills interventions in these patients with hematologic malignancies show that a combination of problem and emotion-focused coping skills can also improve the management of fatigue, especially if individually oriented, more or at least 8 weeks, and with video call better than with a phone call. And hopefully, thanks to this, we can change this tiredness for people having a walk in the Mediterranean Sea, as I hope you all are doing these days, like we see in this Sorolla's painting. And that's all from me. Moltes gracias, and thank you very much.